Welcome to Overheard at Frequency, a podcast exploring issues surrounding hearing loss. I'm your host, Colleen Chapman, and my goal is to bring timely and interesting stories about hearing science, advocacy, and innovation to our listeners. Frequency Therapeutics' mission is to develop therapeutics to regenerate hearing that may one day improve quality of life for individuals with hearing loss. Beyond Frequency's hearing restoration efforts, there are many exciting things happening in the hearing health space, and we cover some of those compelling stories too. In this episode, I sit down with Dr. Nicholas Reed, hearing healthcare researcher at the Cochlear Center for Hearing and Public Health at Johns Hopkins University, where he is the director of the audiology core. Dr. Reed also serves as assistant professor in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health, with a joint appointment in the Department of Otolaryngology, Head and Neck Surgery at Johns Hopkins School of Medicine. Dr. Reed's work is part of the vanguard in hearing healthcare research, and our conversation covers a diverse range of timely issues that may push hearing health forward in positive and concrete ways. We talk about his research on hearing aid comparisons to personal sound amplification products, an extensive study on healthcare spending costs for individuals with hearing loss, and a vision for the future of shifting hearing healthcare from acute care to precision medicine. So, Nick, I followed your work for some time, as I think a lot of people in the hearing healthcare space have. And I was actually surprised. I mean, you're known for, and your team of colleagues at Johns Hopkins is really known for your work in the hearing health space, but particularly with a focus on individuals of the older end of the age spectrum and their experience with hearing loss and the implications for them. So I was surprised to see that you actually started your career in pediatrics, and you're trained as an audiologist, but your original focus was in pediatrics. And it was further interesting to me that you were at Georgetown, which has a soft spot in my heart because both of my children were born at Georgetown University Hospital, and they received most of their early care there. So can you walk us through your journey from starting in pediatrics and then moving on to the work that you came to do and are now doing at Hopkins?
Thanks for asking me to do this and being on. Pleasure is more on my end. It's a big question, isn't it? So I was at Georgetown University Hospital, and clinically, I sort of always, that's not true. I didn't always. Somehow I learned to love pediatrics. I think it's challenging in its own right. And I just enjoyed, as some people in the audience might know, it's a different kind of testing mechanism. And it's not easy to get a 6-month-old or a 1.5-year-old to do a hearing test. And I sort of glommed onto that and was good at it. And then also I did a lot of cochlear implant programming with adolescents, some infants as well, and toddlers, but adolescents. And when you do pediatrics, people forget, I think, about the older end of the spectrum, and that also means working with teenagers and young adults in their transition periods. And for me, what I found at Georgetown was we had, they really are young adults at that point, 21, 22, 23, up to 26-year-olds. Sometimes they're coming off their parents' insurance. Sometimes they're going off to college themselves and they're not, maybe they have their own insurance, but they have these massive life changes, and that comes with different needs. And it also comes with different financial capabilities. Mm-hmm. And I found myself in a situation where I was constantly trying desperately to make sure people had the hearing care and hearing devices that they wanted, what were to fit their needs, if you will. And sometimes that meant getting a little bit creative and looking to sort of our over-the-counter markets and direct-to-consumer markets. And at the time, these are just, amplifier companies that are making some good products, and we were looking for situation specific solutions. So, I can think of a student going off to college and they're struggling in the large auditorium spaces. And so we're looking for something that fits their needs, including talking to the college about advocating for themselves. But as I'm sure people in your audience know, the accommodation systems in education facilities, they're there and they're supposed to be there, but they're really difficult to navigate. And it's hard to get the accommodations you need right away. And we had some unnecessary barriers, in my opinion, by putting the burden on the student, for example, to get the accommodations in each individual class. And so anyway, we went to these direct-to-consumer devices, and this just changed the way I started thinking about the hearing care system. And I quickly, it's you can't avoid older adults either when you're doing audiology. And so I spent plenty of time with older adults as well, and I saw the same issues just for different reasons. They're having trouble getting the devices they need. They're having trouble affording the devices they need. The accessibility is an issue. And it quickly just became clear to me that we have a problem in hearing care. And we essentially had one solution, and you're either on one side of the fence or on the other side of the fence. And honestly, it's all sort of serendipitous that I met Frank Lin, who's the director of the Cochlear Center for Hearing and Public Health at Johns Hopkins. And his work he's known for work on hearing and dementia, but he also was interested in direct-to-consumer amplification. And at the time, we were really calling them, and still to a certain extent, calling them PSAPs, personal sound amplification products. And I sort of just pitched to him wildly, why don't we just start looking at these in a more scientific way and having people use them? And then comparing them even to people using hearing aids. And this led to a piece that I was working on while I was finishing up my training at Georgetown University Hospital. And we showed essentially that for a given individual in a controlled environment on a speech and noise task, using a $2,000 or $3,000 hearing aid versus using various different amplifiers, the hearing aid is the gold standard, and they did best with speech improvement with that, but they didn't do much worse, if you will. I might call it like an equivalence, if you will, of the PSAPs. And so you're looking at like a $350 versus $3,000 device. But the important thing about this study always to remember is we also threw in a really, really junky $30 device, the kind that you see on those made for TV advertisements. And people did worse with that device, worse than without it, because they're so poor. And so this got me on the public health angle.
Yeah, and so the public health angle I want to talk about, because it is really something you've been a leader in talking about, hearing health as a public health issue. You covered so much there. I want to pull apart a couple pieces. One is the access and the navigation you were talking about in an academic setting, and I know you've also worked on it in a healthcare setting, and Peggy Ellertson, one of the people you're partnering with on that, is going to be a guest on a future podcast to talk about those access issues and navigating in a healthcare setting. The Over-the-Counter Hearing Act, which is really active right now, which hopefully we'll talk a little bit about. We view that, even though we're focused on restorative therapies, we view most likely, hopefully if our therapeutic candidate comes to market, will be not, for some people will work alone, but for others, they may need assisted devices or even hearing aids. So it's a broad spectrum of making sure people have everything they need, including the assisted devices, which is why I wanted to get so much into some pieces of your work. And I wanted to talk, so the transition into across the age spectrum, young and old, one of the pieces you've covered is cost from the policy perspective. So if we could talk for a moment about that. Those of us who've worked in healthcare policy for a long time, the Affordable Care Act really addressed access, and there are other things that have come along to work on access, but cost and quality are really complicated challenges that people are working on and that patients really want addressed. So if we could dive into some of what I think is really interesting, some of your work that came out 2 years ago on cost, which was a broad spectrum of patients over 10 years that you tracked. Can you share a little bit with our patient audience what you found about cost as it relates to individuals living with hearing loss?
So what we did was we looked over a 10-year period at 2,300 individuals with hearing loss and 2,300 without hearing loss. And, important for your audience to understand the methods here, and they're rigorous. We matched these folks. We matched them on 38 different indices, including socio-demographic variables, where they lived, economic variables, overall health status, but also baseline health utilization. Just to give you an idea, we have a Caucasian male with a college degree who lives in New York City with hearing loss, and the exact same individual without hearing loss. And so we look at them over a 10-year period. And what we found was that people with hearing loss in this data set incurred over a 10-year period on average $22,000 more in healthcare spending. And that is not broken down by what they're paying out of pocket versus what's paid by the insurance. It's just the overall amount of spending. But no matter which way you break it down, they're spending more on healthcare, and that does mean they're incurring more out-of-pocket costs. And importantly, we're not including hearing care in this. We actually pulled that out. So this isn't something isolated to, oh, well, it's just the hearing loss that you're spending more on. That's completely out of the picture here.
One of the, things as we talk with people about hearing health, we do talk about the preventative side of addressing your hearing early. But there are broader healthcare implications on the quality of care you receive when you're an individual with hearing loss moving through the system, moving through the healthcare system. And so you've done quite a bit of work in that area as well. And I would love to hear your thoughts on what you've found as you've done that research of the quality of care or the way individuals are treated in the healthcare system.
Yeah. So, building off that original work where we looked at these big picture outcomes like, the cost of care overall. And then also in that 10-year study, we saw that adults with hearing loss were more likely to have a 30-day readmission. They were more likely to have an emergency department visit. They had a higher rate of hospitalization. When they go to the hospital, they spend longer there. So we started backing up in the picture here of, well, what is the causal framework here, if you will? What gets us from hearing loss, point A, to these big picture outcomes, point B? And in any scientific study, it could be just that there's some common framework here where both are associated with age, for example. But we pull that out and we control for age in our studies. So it's not just age. And it's not just people with hearing loss perhaps have higher comorbidities. They're more likely to have dementia, for example, which might cost money. We pull these out in our analyses. And so it becomes a question of, well, there's something about the healthcare system that doesn't work for people with hearing loss. And so whether it's communication breakdowns, accommodations, isolation, environmental engagement, these clearly have implications then for things like satisfaction with care. And then also just treatment understanding and time to diagnosis. That communication with a provider is fundamental to patient-centered care. And hearing loss is a barrier that, quite frankly, we don't talk about. We ignore it in the literature for the most part, actually. Mm-hmm. And if you think about it, these bad experiences, I think in the big picture end, what we often leave out of the sort of framework here is it changes help-seeking behavior and it changes preventative metrics. And so what we've seen in our studies are, we did this wonderful study on Medicare beneficiaries. And those with hearing loss they were more likely to say that they would do anything to avoid seeing a doctor or delay seeing a doctor longer than they should. But there were no differences when it came to hearing loss, no hearing loss, and worrying about your health and, disclosing sickness to others. And what that means is that it has nothing to do with people like, healthcare behaviors in terms of, health behaviors in terms of like how much you care about your health. But it has more to do with avoiding the healthcare system. And that makes a lot of sense. If you have bad experiences and communication breakdowns over and over and over again, and you're not understanding your treatments, well, heck yeah, you're not going to go to the doctor when you're sick. You're going to avoid that. You might start to lose faith, if you will, in the system. And this is synergistic when you lose faith in the system, you become more likely to have what we would call a preventable hospitalization, something that we should have been treating in the outpatient setting, things like asthma, COPD, diabetes, pneumonia. These are things that we should catch outpatient and we should treat outpatient. If you end up in the hospital for it, it's a sign of you're not getting the preventative care you need. And we've seen in our own work that adults with hearing loss are more likely to have preventable hospitalizations. And so I think this all is like this long, big pathway, big picture where, it's complicated, but at a basic level, it's communication. There's clearly a communication framework here that we're not providing the accommodations people need. And that's leading to differential healthcare experiences, which leads to worse healthcare outcomes.
So I think it's always helpful not just to talk about the challenges that are clearly being found in the research, but the action that can be taken very specifically to try to begin to address those and remove some of those barriers and problems. So it'll be great to have both this portion from you and a future conversation with Peggy. But, we began talking about your work as an audiologist, and do you feel that your training as an audiologist, your direct work with patients has influenced your approach to public policy and your thinking about it, and your influenced your research and how you focus?
Yeah, I do. I sit at this sort of weird intersection of public health and audiology, and I really don't spend much time in the clinic at all anymore. I'm primarily appointed in a department of epidemiology at Johns Hopkins, and I think what having a clinical background in audiology brings to the table is on our work, we don't approach hearing loss as some sort of one size fits all. And that's often what you might see is, hearing loss is just hearing loss and that's it. But it's not the truth. It's not the case. There's different degrees. No two hearing losses are the same. There's different factors that could affect your hearing loss, like cognitive decline, may affect your ability to compensate in various different situations. And so I think thinking more thoughtfully about hearing changes the way we approach policy, as you see with different degrees of hearing loss affecting different policy levers, or our own work in the hospital where, to your point, we don't just stop at these big picture analyses with epidemiologic work. We take it further, and we have a K-23 NIH funded program to look at, if we address hearing loss in the hospital, do we then modify these outcomes, and do we basically create, cost-effective programs in the hospital to address hearing loss? Reducing incidence of delirium, for example, which costs almost $60,000 per case to the healthcare system. And so when we address that work, we bring in this idea, though, of this is the audiologic framework. And so it's not just a hearing aid, it's communication, it's going further. Not everybody just needs a handheld amplifier. People need different degrees of, intervention. And that sort of, basis in what hearing loss is sort of lost. And so, I get to play this unique role of bringing to nursing, bringing to implementation science, bringing to public health what hearing loss really is, and a deeper understanding of it, creating better, more palatable policy programs, better implementation programs, different ways of thinking about it in general.
So much in what you just said to unpack, but one is that there's no natural path in the experience or the treatment for each individual. And so that's why this emerging or ever growing push for overall hearing health and attention to everything around hearing health, both over the counter, cochlear implants, prevention, addressing stigma, is really exciting. So we've covered so much, but the question I want to ask you before we go is, what do you want to do next? What have you not had a chance to study yet that you are really dying to dig into?
I think there's always room to study more.
Yeah.
There's always room. Building off of my current work, I think I've partnered with a researcher at Yale University, Lauren Ferrante, who's a critical care doctor. And we've started thinking more about hearing loss in the ICU. And I think this is actually really fascinating. Her work um, shows that when we look at post intensive care unit outcomes, so people who leave the intensive care unit, hearing loss is actually predictive of functionality afterwards, and functional decline and functional recovery, right? And so I think this is a very interesting area that we need to think more about, with where I see it as is hearing affecting our resilience, if you will. And this is part of a cognitive issue, but also a functional issue, a functional physical issue, if you will. And then the other area that I haven't tackled at all, but I constantly sort of talk about it in conversation, and I hope someone tackles it. And I think people are trying to tackle it. I think there's a lot of need for new training, is sort of what we're talking about now, where we're talking about various different individuals and the way hearing loss doesn't, no two individuals with the same hearing loss have the same experience. And I think this gets at this idea of precision audiology, and precision medicine is a real field. Mm-hmm. And I'm not saying, people misinterpret when I say this. They think like, oh, well, we do have that, right? Like, but we don't. You go into an audiology clinic, you get any degree of hearing loss, and what's your answer in the end? It's either a cochlear, well, if they don't already have a hearing aid, it's hearing aid. If they've had a hearing aid for a while, or they're an infant with profound hearing loss or severe, you go cochlear implant. And then the systems are essentially the same. We do this long interview where we talk about, what are your needs? What's your environment like? What's this? What's that? And then we come up with pretty much the same recommendations in the end, where no matter what, everybody's saying, well, premium hearing aids be the best for you because it's got the most features. And well, everybody benefits from that. But, why aren't we thinking a step back, and not just what their environmental situations are like and their familial situations are like, but what are cognitive levels of this individual? What's their everyday physical functional capabilities? What are educational backgrounds? What's their work like? What's their long-term goals? And how can we put this all into algorithms to create, well, we think this is the best way to go for you. Like, you need to go to a cochlear implant. There's new sort of hybrid devices, or you fit more of the oral rehab, some communication strategies model. And there are people studying this, but I haven't seen it built into something like the precision medicine framework, truly, where, there's all this talk about patient-centered audiology, but I'm not seeing it on the science side yet. And I think that we can go to that level where we're putting these different aspects in and creating sort of different risk models based off of different variables, and getting people to where we think they should be. And, that's not the end all be all. It doesn't mean it's where you stop, but it does create a more individualized approach to each individual. Individualized approach to each individual. Yeah. Mm-hmm. That's a little bit redundant, but I just think it's where we could go. And I think this is especially important in audiology, moving from an acute care model. And what I mean by that is we took an outpatient care model for acute conditions, and we used it, right? You come to the audiologist, you see them, you have your work done, but it's a chronic condition. And we should be thinking more about what diabetes care has done, where it's moving to integrating smartphones into, your care, and moving into constantly testing. And it's something that it's outside of the clinic. We manage it at the clinical level, of course, and there's a professional involved who has to have a place of work, but it's very much integrated into your entire life. And so I think these sort of two concepts together, precision audiology and moving towards a chronic care model, are where our field can go, and we can create a better hearing care system. And I don't know if I'm going to tackle this or not. I just think this is the most interesting area that we should be tackling, and I would love to find time to do it. But I'm sure as and maybe your audience members probably know, that you have to go deep in academia too, and you have to make sure that you're building off of what you're doing and answering the questions thoughtfully. And so it takes a lot to start a new area of research.
Yeah, and you're also already so prolific in the area that you're working on. You're publishing quite a lot. So time factor, bandwidth factor, I'm sure feeds into it. But That is just a really thought-provoking place to end, Nick. So thank you so much, because it gives us some thinking about where do we go from here? What's next? Where do we spend our time? So um, it was wonderful to talk. And as I said, I would love to have you and colleagues from Johns Hopkins back again, because not only is there so much talk to continue talking about what we covered, but the community health and the public health base of what your whole team is working on is also really intriguing. So really important to patients. So thank you so much, Nick, and all you're doing for taking the time to be together. I really enjoyed it. We hope you enjoyed this episode of Overheard at Frequency. Many thanks again to Dr. Reed for joining us. Please be sure to subscribe to this podcast on YouTube or wherever you listen to podcasts to hear more conversations like this one. Overheard at Frequency was created by Suzanne Day, Colleen Chapman, Jason Glashow, Michael Schubert, Dina Krug, and Zach Russo, and is produced and designed by Daniel Stanish and Diego Chavez. Thank you for listening.